We close our formal program with a conversation about Medicare innovation and what's ahead. Please welcome former CMS Innovation Center Director Liz Fowler in a conversation with BMA President and CEO Mary Beth Donahue.
Great to be here again with all of you. And I mean, I have to say, I would want to give credit to our programming that we're actually ending the day on innovation and future of Medicare. But that sort of ended up working out in the scheduling of things. It's so great that Liz is with us. Her schedule's in demand, and she's so terrific to be here. Just came from a couple-hour meeting that she was so generous to make it all work. But it worked out perfect because we get to focus on the future and we get to focus on innovation. And both of those words connect with the contributions that Liz has made to the healthcare policymaking world at a national level. And I think probably a lot of you have worked with Liz at some point, whether or not she was in the executive branch, the legislative branch, with a health plan in the Medicare Advantage space at the Commonwealth Fund, J&J. And now we're fortunate to have her at Johns Hopkins, where she's focusing on the intersection of health policy and the practice. And I know they have a meeting coming up later this month, I think, that a lot of us are already talking about going to and attending. So Liz, thank you so much for being here. Thanks. And I'm not dating myself as far as how long I've known Liz, but when I mentioned the legislative work, I want to say, I guess we call it the early 2000s.
Yeah, early noughts.
Yeah. But if anything, if there's a benefit to the career path I've taken at certain junctures, I've been able to cross Liz's path. And if any, I'm among many people where we're all better off for it. So thank you, Liz.
Thanks, Mary Beth, and thanks for the invitation to be here to join you.
Thank you. So again, focusing on innovation and just trying to look ahead to Medicare Advantage, because again, I know a lot of the issues we focused on today are sort of the hot button issues right in front of us. But Liz, if you look at just the overarching Medicare program and not just sort of looking through the lens of Medicare Advantage, we at BMA focus a lot on just what defines success for seniors. And that is sort of through that lens that we focus all our policymaking. And so if you can sort of look out like 5 to 10 years on what do you see as the Medicare system that we're looking at, and how do we make it in our policymaking role here, make it sort of work most effectively for seniors?
Yeah, I love this question because the Innovation Center got to think about that and how to make the world look like a better place and what do you need to get from point A to point B. And I like to think of that question in terms of beneficiaries, providers, plans, and taxpayers. And so starting with beneficiaries, in an ideal world, 5 to 10 years from now, Medicare beneficiaries, every one of them has a primary care provider at the center of their care who helps them navigate the system, who helps coordinate their care. There's interoperable health records that allows them to connect their care no matter where they receive it. The care that is delivered is team-based, patient-centered, that addresses health-related social needs, which we now call upstream drivers of health, and helps them stay at home and live in their communities as long as possible. So that's the vision for beneficiaries. And each year they have the choice between a Medicare Advantage plan or a modernized fee-for-service program. And so we need to also think about modernizing fee-for-service and that competition between fee-for-service and Medicare Advantage. And they choose it based on available information and measures that are important to them. On the provider side, we've aligned measures across payers and across programs. We've taken out the administrative burden and really addressed some of the complexity that has taken away the joy of practicing medicine. Providers feel a lot less friction with plans. They get paid on time. They have a navigable system that is predictable and more provider friendly. For the plan side, really fair and predictable payments. And I know that you're all thinking that this is a land of payment policy that has felt not as predictable and not as stable and not as fair. But maybe we get to a point where payments are delinked from fee-for-service on the Medicare Advantage side. And competition really is on providing better care to Medicare beneficiaries. And then for taxpayers, we've managed to bend the cost curve of health spending. And, this isn't an ideal world. You asked me what, in an ideal world. So, and policymakers are fully engaged. So I think what I see as part of the problem with some of our system is that, policies have existed for many years without sort of the oversight and stewardship and sort of ongoing management that needs to happen. And so when unintended consequences happen, those are addressed, policymakers are paying attention. And so in this world, policymakers are active stewards of the program.
Liz, you talked about sort of fair, predictable payments. And as much as I want this conversation to focus sort of future, we have to sort of also still look in the present. And we are in a very turbulent time for lots of different policy issues. But as we narrow down to healthcare, there is a lot of uncertainty and lack of stability around payment policy, and whether or not it could be coming out legislatively and a new Congress and what they're looking at, or just the new CMS leadership. And again, we were fortunate to have CMS leadership here this morning with Chris Klomp and John Brooks, and just communicating their commitment to the program. Obviously, with the advance notice sitting right here, we had to raise questions around payment policies and just not keeping up with medical trends and utilization costs. But again, bringing it back to seniors. When we are looking at these turbulent times, from your lens, what are you watching most closely as you wear this, as you have this role at Johns Hopkins, and you're looking at the various intersections of what's impacting healthcare?
I mean, I think starting just maybe with Medicare Advantage, I look at a lot of the changes like putting aside the utilization and the trends and the disagreements about whether or not the numbers are calculated properly, but I see this as an administration that believes very firmly in the program, but isn't afraid to do what it takes to put it on the right track. And I think what they believe they are doing, and I wasn't here this morning, so I don't have the benefit of having heard from Chris and John, but I believe they think that they're doing the right thing and making the program more sustainable for the future. And it may not feel that way from the perspective of the plans, but I think they really want more competition. They want stable payments. They want a program, I'd say, that has many of the features that I outlined in the first question. So I don't know that their vision is that much different. I think, obviously there is disruption. And I think, part of the challenge is that it's very hard to do sort of one-off changes without sort of taking a step back and looking at the bigger picture. So if you want a better Medicare program and you want Medicare Advantage to look in a certain way, these annual updates and doing it piecemeal is very difficult and complicated for plans. And so, I'm following what they're doing, and I don't have a lot of disagreement with the direction that they're taking. I feel like they are not afraid to sort of make hard choices to do what they think is right. It's not to say I agree with everything, and I'm just talking about CMS here, not talking about where we are on vaccines and other things, but from a CMS perspective, they've got good leadership with a good vision for what they think the program should look like in the future.
Thank you. And again, as Liz came in and as I was speaking with Chris and John after, regardless of where things are laying out right now in the advance notice, is recognizing a commitment to MA seniors and trying to allow the choice and the competition. And I think sometimes we can look at what was in the rate notice and is it really there to encourage competition? And I think it just depends on what hat you're wearing, on whether or not you see that or the data that you have. At the same time, also really appreciate, and this occurred in the comment process in the Biden administration, one of the two administrations that you had worked in, not though I know working directly in Medicare Advantage, but when you're at CMMI, is that it's on us as part of that comment process to bring the data forward to support whatever our recommendations are and where we disagree. So just wanted to reference that as it's coming up. Back to innovation though, and what I love about your career, and I don't know if it's how you see it, Liz, but wherever you've been playing a role in innovation from different angles, whether or not it's designing models or testing them or evaluating them. And I think for focus of everybody in the room, that we see lots of different ideas. But what we in the stakeholder community are focused on is where do we see, change? That there's the good ideas, and some of them, what are the ones that stick? And so if you can, having been in that role at CMMI and now being outside, what do you see that separates reforms from like what truly change needs to be able to make a difference?
So I'm going to answer the question that I want to answer. This is what they teach you when you go through media training. Answer the question you want to answer, and not necessarily the one exactly as it was asked. So I'm going to answer a slightly different question.
Good coaching for the rest of us. But at the same time, anything that comes out of your mouth on this is going to be helpful.
I think, people are critical of CMMI and like, oh, it's not saving money. It's, it needs to be pulled down. It is such a small part of our ability to test new things in Medicare and to a lesser extent Medicaid. But the problem is that the way it's set up, and I worked on the statute, so, some of this is, I take responsibility for the way that it was drafted, but it doesn't really measure success in the right way. And I'll just give you one example that this became such a big issue when I was at CMS. The accountable or health communities model that tested screening and referral for social health needs. So the model ran from 2017 to 2023. Started under the first Trump administration. We continued it and referred patients for social related needs, food, housing, transportation, screened over 1 million beneficiaries, demonstrated that we have reduced ED use, emergency department use, saved money. The final report just came out last week for a model that ended in 2023. So we're not testing and bringing that innovation forward fast enough, I think. There's not a rapid cycle. And so unfortunately, what I saw in my seat was that there were a lot of things that were working. It's just that we didn't have the tools and the ability to scale it. And part of that is the way that the statute was drafted and this use of the word certification. And, we need to certify. It has to be 95% confidence that we're going to save money on a net basis into the future, and nothing meets that goal or that standard. And so nothing is expanded. But from my vantage point, I saw a lot of things that were working in oncology, better oncology care, better way to treat chronic kidney disease and keep people from crashing into ESRD. A lot of the ACO models were really important contributions. And a lot of these innovations are also tested in Medicare Advantage. Medicare Advantage is a really important platform to test a lot of this as well. But then you yank the rug out from under all of these participants by changing the rules because it's not meeting the actuary standard. And it just makes it, I think, a little adding to the sort of complexity and unpredictability. So I'd love to see a more stable approach to innovation. And I'd love to make sure that Medicare Advantage is part of that testing ground and continues to be an important contributor to what we're learning in terms of what can work better in Medicare. But we need to get the results sooner, and we need to be able to scale what works sooner. So sort of an answer to your question.
Yes, no, absolutely. Okay. And thank you for sharing media training with all of us. So as far I hear your point about the testing of MA in the context of that innovation, we obviously in this room see a lot of the value of MA because we see it whether or not we're working directly with seniors or in organizations that are providing services to seniors or we're doing advocacy for them. And so we see the care coordination, how they value supplemental benefits, manage chronic conditions, but we obviously recognize there's room for MA to grow. So in the context of innovation, how do you see where MA is contributing in a positive way to innovation, and where do you see there's room to grow?
So as I said, like a lot of the innovations that CMMI was testing are also being deployed by managed care plans. And it was a really important platform for a lot of things that were being tested and a lot of important potential changes and improvements to care delivery. I think where it could be improved, the Innovation Center hasn't done a lot of testing in Medicare Advantage. We had the value-based insurance design model that towards the end, I think, was bringing more rigor to supplemental benefits, more requirements to invest in those upstream drivers of health. more data availability in terms of who was using benefits and how they were being used and whether or not they improved patients' health. And we had to end that model because it was costing money, not saving money. But I think there's a lot more that could be done in Medicare Advantage to test different innovations specifically in the same way that we're testing innovations in accountable care and in fee-for-service in the traditional Medicare side.
Mm-hmm.
So I guess I would encourage, and maybe this is a hard time to make this ask because obviously there's a lot less funding now for supplemental benefits and probably you're thinking about going in the other direction, but I think there is space to think about what should be tested and what could represent a better program that fulfills, I think, the administration's and what I would say is also my vision for what the future of the program should be.
And bringing it back to the senior, how do you see that they see a difference in how value-based care helps them, not in the context like of a star rating, but more in the care they receive or care coordination?
I mean, I think it's much more personalized. So this is, first of all, no one knows what the definition is of value-based care. And if you asked a senior, like, what do you think of value-based care? I think they would not know what you were talking about. But as I see value-based care, I think about a very personalized approach where they can reach a doctor, a nurse, somebody who has their health record 24/7. More care can be delivered at home. Tech enablement, where there is a high-touch, high-tech approach to reaching beneficiaries and making sure that they're getting what they need, and seeing some excellent examples of some of that. And so I think it can be just sort of more personalized. And I think that's the vision that we all have. And I think we could probably do a better job of explaining what's out there and how that helps beneficiaries. I think we probably haven't done enough to explain what some of those benefits are to the point that people really understand them.
Just as you bring this up, and this is sort of a sideline question, but because of the conversation we just had with Chris Klomp and John Brooks, and Chris talked a lot about AI and just where the prioritization is of AI. And I don't know if this is something, and at Johns Hopkins, it's something that you all will look at some point, but when you think about value-based care, and again, to your point, do seniors really know what that means? But in some of the examples that you just gave on personalized care, when you think of the care that they're receiving now, and some may think with certain AI tools, does it get less personalized, but it could become more efficient? So in the looking out, like the 5-10 years, do you think that with how AI could be incorporated into just the healthcare system more, that there's opportunities for it to not lose the personalization?
I think AI holds an enormous amount of progress and promise for all of us. I mean, how many people are using AI on a pretty daily basis now? And I don't know that my mother and father are there. My dad, who's 88, I'm not sure that he's quite there yet, but he's asking AI questions about what's happening in world events, and so I think he's slowly coming around. I don't know that he's asking about his care and whether he needs a new pacemaker and how to tell whether he needs a new pacemaker, but to him, he's engaging in a way that maybe seniors haven't engaged. It's not a replacement for healthcare, but it can play an important role. I think what I see in AI, and I'm sure anyone in the field now sees this also, is this sort of escalating arms race between providers and plans, where providers are using AI to sort of, make sure they're coding everything that they can possibly code and provide, and plans are making sure that AI is there to catch all the codes that may or may not be supported by the records. And it feels like a little bit of everyone's AI versus AI. And I think there's a better vision for how we can use it to make sure that things run more smoothly, that systems are talking to each other, that more things are automated. I remember when working for Senator Baucus, and we were looking at, you remember the High-Tech Act, or when we talked about the funding for electronic health records way back in, and we got a call. This was going to displace all of the medical transcriptionists. and they were all going to lose their jobs because we were all going to have automated EHRs. We're still not at that point. So similarly, I think AI can play such an important role, but we have to deploy it appropriately and make sure that there's appropriate connection and connectivity across the system. So it just it is not your AI versus my AI, but a system that talks to each other and really enables that better care.
Just again, your reference to Baucus and the EHRs and where they were 20
Many
years
people
ago.
probably don't remember.
No,
Senator
I think a lot of
Baucus.
us do. I'm looking at faces. Yes.
All right.
People
You're
I've
of the
worked with.
age that you
Yes.
still remember who Senator Baucus is.
No, of course. So we
And
started.
don't tell him I said that, by the way.
No, I wouldn't. Great senator. This morning, ironically, we were able to start the day with a leader, again, it was Chris Klump, talking about optimism. And so it's just the irony that one of the questions I wanted to close with, it relates to optimism as well. And it's when you look at the Medicare program that we have now and wanting to focus on how it can best serve seniors, what leaves you optimistic that looking ahead the 5-10 years, Medicare can improve, whether it's policy or operations, to serve seniors better? So when we're in these day-to-day struggles and there's affordability issues or access issues, but there's just the overall value in the program, and I'm talking about fee-for-service or Medicare Advantage, just Medicare in general. What gives you optimism?
I mean, I think you don't run the Innovation Center unless you have that level of optimism. You have to believe that everything could be better than it is today, and you want to have that, curious spirit to try to find those innovations. And so I consider myself an optimistic person. I think as I look across the system, the U.S. healthcare system generally, we're at a point where there's a lot of unhappiness, and it sort of doesn't matter what chair you sit in. And that frustration is sort of bubbling up to the point where I feel like we're on the verge of having another national conversation about healthcare, not just Medicare. And I think some of the Medicare challenges are going to come sooner than later. But the whole healthcare system, and maybe some of the HR1 changes start to come into effect. The premiums and the effects of not renewing the enhanced subsidies, and people are unhappy and feeling like healthcare is unaffordable and not listening to them. And I think we're on that verge of another national conversation that I think could be bipartisan. Call me Pollyanna, but I truly believe that if we want to solve these problems, we need to sort of come together and recognize the common challenges and the common solutions. That was always the vision that Senator Baucus held out, was that it's more lasting if we can come together as a nation and figure out what those problems are and what the solutions are. We're clearly not at that point right now, but I'm optimistic because I continuously and continue to believe that vision is possible and that we can come together as a country and help solve these problems. And I do think, in terms of Medicare, I think some of these challenges are going to come to the forefront and will become a political issue that people are going to have to solve and come together to solve them.
Well, if there's going to be a national healthcare conversation at some point, I know everyone here would agree that we would want you a part of it, both with your expertise, but also your optimism, never mind your experience.
Thanks
So
very
please
much.
join me in thanking Liz for being with us.